Howdy, Michael Davies here with the pharmaceutical company. We will talk a little bit about the use and dosage of the drug and some of the side effects this medication. Glucophage is indicated as an adjunct to diet and exercise to improve glycemic control in adults and pediatric patients 10 years of age and older with type 2 diabetes mellitus. Glucophage XR is indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes mellitus. Adult dosage Glucophage. The recommended starting dose of Glucophage is 500 mg orally twice a day or 850 mg once a day, given with meals. Increase the dose in increments of 500 mg weekly or 850 mg every 2 weeks on the basis of glycemic control and tolerability, up to a maximum dose of 25-50 mg per day, given in divided doses. Doses above 2,000 mg may be better tolerated given 3 times a day with meals. Glucophage XR. Swallow Glucophage XR tablets whole and never crush, cut or chew. The recommended starting dose of Glucophage XR is 500 mg orally once daily with the evening meal. Increase the dose in increments of 500 mg weekly on the basis of glycemic control and tolerability, up to a maximum of 2,000 mg once daily with the evening meal. If glycemic control is not achieved with Glucophage XR 2,000 mg once daily, consider a trial of Glucophage XR 1,000 mg twice daily. If higher doses are required, switch to Glucophage at total daily doses up to 25-50 mg administered in divided daily doses, as described above. Patients receiving Glucophage may be switched to Glucophage XR once daily at the same total daily dose, up to 2,000 mg once daily. The recommended starting dose of Glucophage for pediatric patients 10 years of age and older is 500 mg orally twice a day, given with meals. Increase dosage in increments of 500 mg weekly on the basis of glycemic control and tolerability, up to a maximum of 2,000 mg per day, given in divided doses twice daily. Glucophage is available as tablets, 500 mg round, white to off-white, film-coated debossed with BMS 6060 around the periphery on one side and 500 debossed across the face of the other side. Tablets, 850 mg round, white to off-white, film-coated debossed with BMS 6070 around the periphery on one side and 850 debossed across the face of the other side. Tablets, 1000 mg white, oval, biconvex, film-coated with BMS 6071 debossed on one side and 1000 debossed on the opposite side and with a bisect line on both sides. Glucophage XR is available as extended-release tablets, 500 mg white to off-white, capsule-shaped, biconvex, with BMS 6063 debossed on one side and 500 debossed across the face of the other side. Extended-release tablets, 750 mg pale red and may have a mottled appearance, capsule-shaped, biconvex, with BMS 6064 debossed on one side and 750 debossed on the other side. There have been post-marketing cases of metformin-associated lactic acidosis, including fatal cases. These cases had a subtle onset and were accompanied by non-specific symptoms such as malaise, myalgias, abdominal pain, respiratory distress, or increased somnolence. However, hypotension and resistant bradyarrhythmias have occurred with severe acidosis. Metformin-associated lactic acidosis was characterized by elevated blood lactate concentrations, anion gap acidosis, without evidence of ketonuria or ketonemia, and an increased lactate. Metformin decreases liver uptake of lactate, increasing lactate blood levels, which may increase the risk of lactic acidosis, especially in patients at risk. In Glucophage clinical trials of 29-week duration, a decrease to subnormal levels of previously normal serum vitamin B12 levels was observed in approximately 7% of patients. Such decrease, possibly due to interference with B12 absorption from the B12 intrinsic factor complex, may be associated with anemia but appears to be rapidly reversible with discontinuation of Glucophage or vitamin B12 supplementation. Certain individuals, those with inadequate vitamin B12 or calcium intake or absorption, appear to be predisposed to developing subnormal vitamin B12 levels. And insulin secretagogues, for example, sulfonylurea, are known to cause hypoglycemia. Glucophage XR may increase the risk of hypoglycemia when combined with insulin and/or an insulin secretagogue. Therefore, a lower dose of insulin or insulin secretagogue may be required to minimize the risk of hypoglycemia when used in combination with glucophage. Because clinical trials are conducted under widely varying conditions, adverse reaction rates observed in the clinical trials of a drug cannot be directly compared to rates in the clinical trials of another drug and may not reflect the rates observed in practice. Limited data with glucophage in pregnant women are not sufficient to determine a drug-associated risk for major birth defects or miscarriage. Published studies with metformin use during pregnancy have not reported a clear association with metformin and major birth defect or miscarriage risk. There are risks to the mother and fetus associated with poorly controlled diabetes mellitus in pregnancy. No adverse developmental effects were observed when metformin was administered to pregnant Sprague Dawley rats and rabbits during the period of organogenesis at doses up to 2 and 5 times, respectively, a 25-50 mg clinical dose, based on body surface area. Published data from post-marketing studies have not reported a clear association with metformin and major birth defects, miscarriage, or adverse maternal or fetal outcomes when metformin was used during pregnancy. However, these studies cannot definitely establish the absence of any metformin-associated risk because of methodological limitations, including small sample size and inconsistent comparator groups. Limited published studies report that metformin is present in human milk. See data. However, there is insufficient information to determine the effects of metformin on the breastfed infant and no available information on the effects of metformin on milk production. Therefore, the developmental and health benefits of breastfeeding should be considered along with the mother's clinical need for glucophage and any potential adverse effects on the breastfed child from glucophage or from the underlying maternal condition. The safety and effectiveness of glucophage for the treatment of type 2 diabetes mellitus have been established in pediatric patients 10 to 16 years old. Safety and effectiveness of glucophage have not been established in pediatric patients less than 10 years old. Use of glucophage in pediatric patients 10 to 16 years old for the treatment of type 2 diabetes mellitus is supported by evidence from adequate and well-controlled studies of glucophage in adults with additional data from a controlled clinical study in pediatric patients 10 to 16 years old with type 2 diabetes mellitus, which demonstrated a similar response in glycemic control to that seen in adults. Metformin is an anti-hyperglycemic agent which improves glucose tolerance in patients with type 2 diabetes mellitus, lowering both basal and postprandial plasma glucose. Metformin decreases hepatic glucose production, decreases intestinal absorption of glucose, and improves insulin sensitivity by increasing peripheral glucose uptake and utilization. With metformin therapy, insulin secretion remains unchanged while fasting insulin levels and day-long plasma insulin response may decrease. Active ingredients of glucophage: metformin hydrochloride. Inactive ingredients in each tablet of glucophage: povidone and magnesium stearate. In addition, the coating for the 500 mg and 850 mg tablets contain hypromellose and the coating for the 1000 mg tablet contains hypromellose and polyethylene glycol. That's all for today. Subscribe to the Pharmacological channel and stay with us. Good luck.